So I was asked to speak to adult onset Still's disease. Febrile disorders do occur in adults. The question is, what do we commonly see? Mainly because it's the most common cause, autoimmune or rheumatic cause of fever of unknown origin. The name Still's disease always comes up. So it's high on the list when rheumatic patients are falling under rheumatic evaluations. But there are other things that can give you fever, and I have those listed on the left. And they're sometimes confused with adult Still's disease. If you look at the spectrum of autoinflammatory disease, there's a few that preferentially affect adults, as was just mentioned, Schnitzler syndrome. There is this adult onset of CAPS, and that's a minority population in the CAPS population. But you can see that when you start looking at TRAPS and FMF, and specifically Muckle-Wells, it's a minority of adults who will manifest and be proven to have those specific diagnoses. This is a patient that I started with, I think this is 1982. She was 23. She was petite, frail, but fierce, admitted to the hospital at 6 a.m., looked very, very sick. Do we put her in the ICU or not? She presented with a temperature of 104, a SED rate of 99, a white count of 20,000. Her liver enzymes were off the chart. You can see that early on she manifested a remittent pattern of high spiking fevers that would occur twice a day. And then once we put her on salicylates, she fell into a classic quotidian pattern, falling back to baseline. And it wasn't until she went on steroids in high doses, started out with 10, went up to 50 or 60, I think, you see that the fever pattern starts to break up, comes down in magnitude, spaces out in its frequency. Along the way, she had SED rates over 100. She had a white count that went up as high as 40,000. She dropped her hematocrit. Her LFTs were fivefold elevated. And this was not her first diagnosis. She had unknown diagnoses in the ages of 9 to 12 at another hospital in Brooklyn where she was called rheumatic fever or hepatitis and whatnot. And here she was 23, some 11 years later, presenting with a new presentation of what was to be adult Still's disease. So what is Still's disease? It is a systemic inflammatory disorder. We know when it occurs after the age of 16, it's adult onset. And I think the majority of these really are up to age 35, as I'll show you why. It is a condition of quotidian fevers, evanescent rashes, polyarthritis, sore throat, serositis, organomegaly, a really exuberant acute phase response with high white counts. It is a syndrome. It's not a diagnosis that we can have a test for, and we have tests that will help maybe exclude other things. So we need to exclude other diagnoses, and this is one of the biggest problems in the diagnosis of this, in that you have to go through a process to get to this diagnosis. I think it's easily identifiable to those who have seen this, which is why pediatric rheumatologists are much better at this than are adults. It is a condition that has a systemic onset, systemic exacerbations, and some will or will not have chronic arthritis that will go on and on and on. And then there may very well be disease-free intervals, as was shown for the patient I just presented. If there's any discussion about whether systemic onset JIA and adult onset disease are the same, you can look at this comparison. This was early on big studies, more than 15 patients, about 100 to 50, or 150 in each group. You can see they're, line by line, they equal in their presentation, with the only major difference being that of the prodromal sore throat. The patient who presented to me started out, her story was she had a sore throat. She went to her family doctor. She got ampicillin. She developed a rash. They said, uh-oh, what is a reaction and it turns out her rash was her Still's rash. The sore throat was a prodromal sore throat. And then she ended up in the hospital some 7 days later. So the challenge is here that this is a very common cause of FUO on patients who will present with FUO. It has a considerable amount of morbidity to it, thankfully not much in the way of mortality. It is a diagnostic and treatment challenge. Along the way, they will often be hospitalized. They will often be seen by other consultants before they're seen by rheumatologists. They will have serositis, weight loss. They could have pericardial tamponade. MAS is not as big a problem in the adults, but it's still a big problem in the adults as it is in the pediatric form of this disease. And they are often confused about whether they have infectious issues going on at the same time. Maybe the big long-term problem is that at least a third seem to develop a chronic polyarthritis that can look just like rheumatoid arthritis, be just as damaging and erosive. How common is this condition? You can look at this many different ways. I'll show you some epidemiology, but looking at large series from usually major departments and medical centers, you can see over a 20-year period, Bywater's reported 14 cases. Many large departments will see at least 1, maybe 2 cases a year. That's kind of the normal occurrence rate. If you look at FUO series shown on the bottom, you can see that it ranges from anywhere from 5% to up to 9 or 11% of the cases of FUO, making it the #1 rheumatic disease or musculoskeletal cause of an FUO. So again, you should see this, you should know about this. The occurrence rate, the incidence rate is about 1 case per 100,000. In the United States this year, there'll be somewhere around 4,000 new cases. Depending on where you live, you can see what the case rate may be in your city based on the population size of your city. So where I'm from, in Dallas, there'll be 19 cases. I might see 2 or 3 of them, and I'm very well known in Dallas as the guy who knows about Still's disease. I see a lot of other patients from a lot of other cities, but there are a lot of other cases that are being seen by internists, infectious disease specialists, and other rheumatologists in my city. So at onset, this is based on early reports from like 1970 to around 1985 when I made this, when I think the reports were very accurate. Current reports are mixed in with a lot of other things, and there's a lot of bias, I think, errant reports that are out there. I think these are true reports because they pretty much fit the syndrome as described by Bujak at the NIH and Bywaters both around 1970. And you can see that really 76 or 3/4 of cases occur before the age of 35 when they occur in the adult population. About 20% will actually have had some kind of history back when they were a child of having some kind of systemic inflammatory febrile illness. You can see that the sex distribution is equal between males and females. Above the age of 50, it's not many. It's somewhere about 9% of patients will present above the age of 50. So the older the patient is, the more you really should doubt this diagnosis, especially since a lot of older patients have an atypical presentation. The hallmark here is there's 3 of them, right? There's the quotidian fevers, the evanescent rashes, and the polyarthritis. You really have to have those to start. Now, at the outset, you may not have all 3 of those. But certainly in the first 6 months, you will in the vast majority of people. Quotidian fever is a fever that rises above 39 degrees centigrade and returns to normal in the same day. And the interesting thing that I learned when I was doing a review of the University of Pittsburgh patients as a resident is that when I asked a patient, when did you get your fever, they all did the same thing. They all would look at a clock on the wall and they would say some crazy number like 11:15 p.m. or 2:21 a.m. And it was almost always late at night, sometimes late in the afternoon, never in the morning. There was a true circadian pattern to their disease. And it was predictable. And they knew it was going to happen because they would get the shaking chills, the spike in fever that would last an hour or 2 or 3, and then they would defrevesce, drench their bed sheets, change their clothes, look pretty good in the morning. So the fever pattern is important, but if you read about fever patterns and know about fever patterns, they're not that specific. You know, there are a lot of things that can look like this. The same can be said of the rash. I once lectured at the American Academy of Dermatology, and I got booed off stage when I said what Eric Bywaters told me. Eric Bywaters, I got a chance to meet him when I was a fellow, and I said, what's the most distinctive aspect of this disease and how you make the diagnosis? He said, it's the rash. It is that faint salmon pink maculopapular with areas of coalescence that may or may not be itchy and has the associated features of Kebnerization and dermatographism. Dermatographism being where you scratch yourself, you get an exaggerated wheal and flare. Kebnerization being where you scratch yourself, you later on get a rash in the distribution of traumatized skin. He said that that was absolutely characteristic. Again, all the dermatologists said it's a morbilliform viral exanthem. they look the same. And if you think, now Koebnerization and dermatographism, that's a little more specific. But as much as we'd like to make a lot about this, it's not that specific. But again, when you start stringing these together, you'll see other things. Again, pruritus and urticaria, 30–40% of patients. Other things, facial rash, alopecia, plaques, well, not so often, right? Here's a resident's mother who came to see me. She's got, and a lot of them have a V-neck kind of look that looks very much like dermatomyositis. And there's often a confusion between adult Stills and patients with dermatomyositis. Here's a very faint rash. Most of the old pictures of rashes look like they're brown or green or something because we had really bad cameras back then, or you're taking reproductions of journal articles. The arthritis is important. On the very far right is the experience in 21 patients at the University of Pittsburgh. The onset being the first 6 months of disease and how many joints were involved. So 11 out of the 21 had shoulder involvement. 19 out of 21 had knee involvement. And then the course is after 6 months and over the course of their disease. You can see that early on they get a polyarthritis. It's small and large joints, but later on it tends to be mostly the wrist, knees, ankles, maybe shoulders, and then some will have small joints, and those are the ones that are going to have chronic polyarthritis that looks like RA. So myalgias, arthralgias predominant when they're acute, hot, inflammatory. They can get fleeting arthritis to start with. Within 6 months, most of them will develop a polyarthritis. A monoarthritis, sorry, not Still's disease. You got to worry about that. You should think about other diagnoses. Carpal ankylosis, I learned this from Tom Metzger and Wally Christie. In their patients that they saw this unique pattern of ankylosis of the wrist in a pericapitate distribution that was sort of distinctive. So this is one of, like, I have about 5 of these kind of pictures. This is L.K. Larry, they called him. You can see that when he presented in August '72, pretty normal looking wrist. 7 months later, oops, not so normal. He's starting to fuse his capitate to the second and third metacarpal over here against the tamate, clearly fused to the lunate and starting over here with the scaphoid. So this pericapitate pattern of distribution, very specific for Still's disease, but if you look at if you go to hang out with radiologists and they say, when you see this, what do you see it in? Well, you're likely to see it's a rare manifestation of RA, it's a rare manifestation of psoriatic arthritis, so you'll see probably more pericapitate ankylosis from those disorders because they're much, much more common. But if you're considering Still's disease, this develops in 50% of patients. Other things that are distinctive, the weight loss can be as dramatic. Things that really go like this in Still's disease, not only how they feel, but their weight drops, their hemoglobin drops, their albumin drops. These all happen in a matter of weeks, 2 weeks, maybe 3 or 4. 2/3 will have hepatic dysfunction, hepatosplenomegaly, pleuritis, pericarditis, serositis at about 40%. Myocarditis is rare. That's one patient I saw as a resident. He had, you can see, he has almost white out in his lung. He's got big pericardial pleural effusions, and he had myocarditis on endomyocardial biopsy. This gentleman got reported twice in the literature. Once for the myocarditis, second because he developed an inflammatory orbital pseudotumor. The labs are equally distinctive. This is what usually scares the clinician as much as looking at the patient, because the patients look sick at the outset, but their labs make them look worse because they have this tremendous white count that you can see the median levels here about 20,000. The highest that I've ever seen is 70,000, 73,000 actually. They should be seronegative for rheumatoid factor and ANA. They should have a leukocytosis with a strong left shift, anemia, chronic disease. They will all have some kind of elevated acute phase reactant, and we make a big deal out of the hyperferritinemia, but realize it's only seen in half the patients. So while it may be very specific, and it's not that specific because it's seen in iron overload states, I've seen more hyperferritinemias and vasculitis and lupus than I've seen in Still's disease, if you're talking about actual raw numbers. But again, this makes people really excited and thinking, oh, well, it will be. Most ferritin elevations in Still's disease are going to be 900, 600, not 25,000. But again, when you see that, that's a nice clue, and it may have some specificity to it, and I'll show you that. The differential diagnosis here is quite wide. Viral syndrome usually means we don't know, and they resolve in weeks to months. Dermatomyositis, reactive arthritis, IBD, lymphoma, leukemia, those would be my highest on my list of what I've seen. Who diagnoses this easily? Pediatric rheumatologists. You tend to see more of this. You're better at it. You know the pattern, and I think it works out much better. most adult rheumatologists get the patient handed off to them, I think, from the ID guy. Well, it turns out that's not true. They get them more from hospitalists, but the patient's already been seen by ID, and ID has said, sorry, we're done. It's not an occult infection. It's probably Still's disease or some rheumatic thing, and then the rheumatologist gets involved. Rheumatologists who know the criteria, the problem is, unless you're in this room, you don't know the criteria. And my main gripe, I see a lot of consults of patients who have Still's disease, is that it's a diagnosis that's thrown around like nickels when it should be thrown around like manhole covers. And meaning that when they have a febrile illness, you don't know what it is, you call it Still's disease, because no one in the real world is applying criteria very well. There is a lot of misdiagnosis. I think these are two studies I find interesting. This is a cohort of systemic JIA patients who met ILAR classification criteria for SJIA, but when they looked at them, half of them actually had failed to meet, what's this? I'm confusing this with the second one. So they had the triad, but half of them failed to meet the criteria for I get those confused, for ILAR criteria, because they usually didn't have a true quotidian fever, right? And ILAR criteria, you have to have that. And another review done by people at Stony Brook looked at a literature review of both SJIA and adults, 162 patients, who actually underwent genetic testing, and they saw that a third of them had a monogenic disorder that was identified, by one of the genetic testing that was done, and 4 more that had either FMM or TRAPS, so a total of 35 patients, I guess. So they are often misdiagnosed, and they may get there eventually, but they're all, again, I show you some examples of what the diagnoses that are considered. I think you need to know the criteria. So there's Yamaguchi criteria. These are often used because they were tested and have a specificity and sensitivity that's high, over 90%. I don't know that really going to hold up if it was a well-done, had a good control group to compare it to, but nonetheless, it's pretty good. Here you have to have 5 or more criteria, and 2 of them must be major. The majors are fever greater than or equal to 39, arthralgia, and that's only for 1 week fever. That's a bit of a problem. Arthralgia for 2 weeks or more, the Still's rash, and a neutrophilic leukocytosis with PMNs greater than 80%. The sore throat, hepatosplenomegaly, lymphadenopathy, hepatic dysfunction, and seronegativity. These are helpful. My criteria published, I actually came up with these when I was rotating at Pittsburgh in 1984. I published them in 2000 in Bulletin of Rheumatic Disease. Here I'm giving you 2 points, and you need 10 points to have the diagnosis if you have the 5 things I deemed were the most specific for the condition and excluded a lot of other things. So the quotidian fever, you really have to have. The Still's rash, the simultaneous elevation of white count and SED rate. That takes care of a lot of other problems, but both need to be elevated. You could substitute a CRP or a ferritin in there. They should be seronegative, and again, half will have carpal ankylosis. You get 1 point for onset age less than 35, polyarthritis, sore throat, that's prodromal, RESs, hepatosplenomegaly, lymphadenopathy, or LFT elevations, serositis, cervical or tarsal ankylosis, not commonly seen, but can be helpful in this diagnosis. Again, you have to have it for a while to be a probable diagnosis. The first 6 weeks, I think it's at best a possible diagnosis. What we found in Pittsburgh is that you can prognosticate a little bit based on how they're going to behave. There were 4 patterns of disease. People had 1 spike, 21 patients, 4 of the 21 had 1 spike of systemic disease that lasted months to years. They had multiple spikes with disease-free intervals in 2 cases. Then the same pattern, except throw in chronic arthritis on the bottom. That takes care of most patients. 10 with polysystemic, 1 with monosystemic with a chronic articular in 5 patients. We saw that it was the arthritis that actually determined the long-term outcome as far as functional outcomes, and that's shown here. If you divide them up by the onset and course, you can see it's these patients over here who had a polyarticular onset and a polyarticular course who are more likely to be functionally impaired in long-term follow-up. Patients with Still's disease do die, but usually not from Still's disease is what I say. It's more likely to be related to complications of steroid therapy. If you're dealing with a pediatric population, the fatality rate with MAS is anywhere from 8 to 37%. It can be very high. So obviously infection, when it is present, DIC and lung disease are major contributors. A study done by Mehta and colleagues looked at the National Inpatient Service, about 8 million hospitalizations. They found 5,800 Still's patients who were hospitalized and found a mortality rate of 2.6%. It was about I think the number was about, if you were 62 as opposed to 52, their average age was 53, that there was a higher rate of mortality, and it was actually six-fold higher if it was an Asian hospitalization. They did have about 1% each of MAS cases, DIC, or TTP. So these are rare variants, but they're the scary things that do happen in Still's disease. What does this do to? This is a circadian cytokine, a circadian inflammatory inflammasome disorder. IL-1 has a circadian rhythm to it. So does IL-6. IL-1 peaks here at about 10 p.m. It drops down by 8 a.m. Endogenous cortisol is low during the night and then comes up about 7 or 8 a.m. in the morning. That's why you almost never see fever in Still's patients in the a.m. This is a presentation, Van Riel, who did IL-6 levels here peaking again, or in this case around 8 p.m. And 2 hours later, they had a febrile spike, and then this dropped overnight, and again, supporting a cytokine-driven circadian disorder. The keys to diagnosis is that daily circadian thing, the Still's rash, using criteria. You know, a response to IL-1 inhibition, as was mentioned earlier, really is very helpful. I've seen patients with infections get better and lymphoma get better with IL-1 inhibition, so it is not specific. And until we have a true test. And whether or not they should have genetic testing, I think the more atypical the patient, the more you should be doing genetic testing. We do a sort of molecular phenotypic analysis. Virginia Pasquale, I think, might talk about this tomorrow. And using microarrays of PBMs from Still's patients, there's a pattern which is, she calls this the signature. And it's, it's strong for inflammatory signals, neutrophil signals, sort of downregulation of B cells and T cells. And this is seen, and when they're red hot, they look exactly like this. When you treat them, it fades. It doesn't go away. When it goes away, all these colors go away. It's a blank analysis, more or less. So that's a useful thing in following patients, and we've done that serially. We do genetic testing, again, when the patient has an unknown diagnosis or especially is atypical, but it is a problem in getting this paid for and done. Monitoring articular disease is easy. Systemic disease is hard. Fever, rash, hepatosplenomegaly, the features of disease. Acute phase reactants are again, I'll do ferritin. This neutrophil to lymphocyte ratio can be helpful. This is one analysis here showing you that ESR is better than doing nothing, I guess. And this is CRP better than ESR. This is ferritin right here, this dotted line that I'm showing you. But the neutrophil lymphocyte ratio, I may have better predictive value. I learned from Lynn Pinero in Virginia that aldolase is a strong biomarker for inflammasome activity. When these people are hot and flaring, their aldolase levels go up and their CPK levels are normal. And it doesn't always parallel their LFTs. I believe there's a connection between aldolase activity and inflammasome activity. Others have reported the use of S100 proteins like calprotectin, IL-37, and IL-18, but again, these are not widely available. And then maybe microarrays in the future. Fever is an issue. Patients come in and say, I've got a fever, and you don't know because they look pretty good today and they're not fever. I ask patients to, and I've followed a few now, where they buy this off of Amazon for $25. It's a patch you put in your axilla, and Bluetooth connects to your phone, and they can come in and they can show you what their fever pattern is. There's no guessing. There's no recording. There's no trying to decipher what they put on note paper. This can be a useful and fairly inexpensive tool. The approach is fairly simple. High doses of nonsteroidals and or steroids. Still's disease should not respond to 10 or 20 milligrams a day. If they have arthritis, if they're not doing well, they should get a higher dose of steroids with methotrexate. And I usually will quickly use an IL-1 inhibitor. Your options are many here. You could use an IL-6 inhibitor as well. These are expensive. I like Kineret for its fast response, and also when you discontinue it, if they still have activity, they'll flare within 3 days. There is something to be said for possibly using a JAK inhibitor, calcineurin inhibitors, if you come from a country where IL-1 inhibitors are not available, or if you're treating MAS. And I have had patients who responded instead of using an IL-1 inhibitor to a JAK inhibitor. But that's not been studied. Articular disease, you treat just as if you have polyarticular JIA or adult RA with methotrexate combination therapy. This is where TNF inhibitors are useful. TNF inhibitors should not be used in systemic disease. So I'll end there. You can read my summation. I think that, again, the addition of IL-1 and IL-6 inhibitors has been a major advance. I think the criteria need to be tested and retested and widely spread. And knowing how to monitor patients can be very helpful in knowing when to continue therapy or stop therapy. Thank you very much.